Hyperkalemia is when there is high levels of potassium in the bloodstream. The normal range lies usually between 3.6 to 5.2 millimoles per liter, but in hyperkalemia, the potassium levels increase to greater than 5.5 millimoles per liter. Symptoms that the patient may experience include muscle weakness, numbness and fatigue, nausea and vomiting, and in severe hyperkalemia, irregular heartbeats. The causes of hyperkalemia can either be due to certain conditions or medication. So let's have a look into the conditions first. A common cause is normally when your kidneys are not functioning properly, usually because of acute kidney injury or chronic kidney disease. Normally, one of the functions of the kidneys is to get rid of the potassium from the bloodstream by excreting it into the urine. But when the kidneys are not functioning properly, the potassium cannot be excreted via the urine, causing it to build up and as a result cause hyperkalemia. Another condition that can cause hyperkalemia is Addison's disease. Addison's disease is when the adrenal gland, which lies on top of the kidneys, does not produce enough cortisol or aldosterone hormones. Normally, high levels of potassium stimulate the adrenal gland to secrete the hormones cortisol and aldosterone. One of the functions of aldosterone is to act on the kidneys and increase the excretion of the high levels of potassium via the urine, and this then lowers the potassium in the bloodstream. But in Addison's disease, there is very little aldosterone secretion, which means less aldosterone is available to act on the kidneys, causing less excretion of potassium via the urine. This then prevents the potassium being lowered in the bloodstream, causing hyperkalemia. Another cause which is common is diabetic ketoacidosis, but the management of hyperkalemia because of diabetic ketoacidosis is not the same as covered in this video. So in patients who are type 1 diabetic, a lack of insulin means their blood sugar levels will increase. However, the body needs an energy source, and because there is no insulin available, it starts to break down fat cells for energy, which releases ketones. This causes acidosis, meaning the pH of the blood drops and the blood becomes acidic. This then causes potassium to move from the cells into the bloodstream, causing hyperkalemia. Another common example is tissue destruction, which causes hyperkalemia. When a tissue is destroyed, it releases its content, including potassium, into the bloodstream. Examples include rhabdomyolysis, which is a breakdown of damaged muscle, trauma, burns, and tumor lysis syndrome. Tumor lysis syndrome is when a tumor cell ruptures and releases its content into the bloodstream. Certain medication can also cause hyperkalemia, and some of these act on the renin-angiotensin system. So let's have a look at this briefly. Normally, the liver produces an hormone called angiotensinogen, which is converted to angiotensin 1 by an enzyme called renin. Renin is secreted by the kidneys. Angiotensin 1 is then converted to angiotensin 2 by an enzyme secreted from the lungs called angiotensin converting enzyme, also referred to as ACE. Angiotensin 2 then stimulates the adrenal gland to secrete aldosterone, and as mentioned before, one of the functions of aldosterone is to act on the kidneys and excrete potassium through the urine, causing a lowering of potassium in the bloodstream. So the first drug that can cause an increase in blood potassium concentration is an ACE inhibitor. It blocks the enzyme ACE and so prevents the conversion of angiotensin 1 to angiotensin 2. This then prevents the release of aldosterone, causing hyperkalemia. Another drug that can increase blood potassium concentration is angiotensin 2 receptor antagonist. It prevents angiotensin 2 from stimulating the adrenal gland and so preventing the release of aldosterone, causing hyperkalemia. Another class of medication are aldosterone antagonists. Examples include spironolactone and eplerenone. These inhibit aldosterone function. Also, uncommonly, heparin may also reduce aldosterone function, and as a consequence, cause an increase in blood potassium levels. Non-steroidal anti-inflammatory drugs, also referred to as NSAIDs, are another class of medication. They block the action of renin by inhibiting prostaglandins. This then prevents the conversion of angiotensinogen to angiotensin 1, and so eventually lead to inhibiting the function of aldosterone, causing hyperkalemia. Other medication include potassium-sparing diuretics such as amiloride, non-selective beta blockers, potassium supplementation, and digoxin. Let's have a look at the ECG changes that can occur during hyperkalemia. This is the look of a normal P wave and QRS complex, with the T wave being quite round and U wave very shallow. But in hyperkalemia, the P wave becomes flattened, the PR interval is prolonged, and there is a broadening of the QRS complex. The ST segment also becomes depressed, and there is a very high peak in the T wave. Let's have a look at the treatment and prescribing in hyperkalemia. The first drug is intravenous calcium gluconate. This drug doesn't actually reduce the high levels of potassium in the blood. So looking at this diagram, very high levels of potassium in the blood are damaging to the heart. This is because high potassium can cause excitation of the heart, causing arrhythmias. However, intravenous calcium gluconate works by protecting the heart and so prevents damage from the high levels of circulating potassium in the blood. It achieves this by stabilizing the cardiac membrane. The ECG changes that have occurred should return back to normal within 1 to 3 minutes, and the effect of intravenous calcium gluconate should last up to approximately 30 minutes. When prescribing intravenous calcium gluconate, there is a great risk of precipitation causing thrombosis if given at the same time and through the same line as other potassium lowering drugs such as insulin or sodium bicarbonate. Another key point is that if the patient is taking digoxin, the intravenous calcium gluconate should be given over a slightly longer time period and administered at a much slower rate. This is because if the calcium gluconate is given too quickly, it can worsen digoxin toxicity. The second drug is called calcium risonium. This drug lowers potassium levels in the blood by preventing the potassium reaching the bloodstream in the first place. So normally, potassium reaches our bloodstream from the intestine, and this potassium ultimately comes from the diet. Calcium risonium prevents this from happening. It works by exchanging potassium for sodium in the intestine, causing the potassium to leave the intestines by being excreted in the feces, which then prevents potassium from reaching the bloodstream. It takes approximately 2 to 6 hours for calcium risonium to have a potassium lowering effect. And it can be prescribed as 2 formulations. It can either be given orally at a dose of 15 mg 3 times a day or rectally as an enema for patients who are unable to swallow at a dose of 30 mg once a day. One of the common side effects of calcium risonium is constipation, and because of this, there may be a need to prescribe a laxative alongside it, commonly senna, at a dose of 7.5 to 15 mg twice a day. Another 2 drugs that are used to lower potassium levels are insulin and salbutamol. They both work in the same way by promoting uptake of potassium by the cell using a sodium-potassium ATP pump. Insulin and salbutamol cause a leakage of potassium from the bloodstream into the cells, which causes a decrease of potassium in the bloodstream and an increase of potassium within the cell. But this is only a short-term solution, because once these drugs are stopped, the potassium will just leak back into the bloodstream. Salbutamol is normally prescribed at a 10 mg dose via a nebulizer. And because you want the potassium lowering effect to happen very quickly, normally a fast-acting insulin is prescribed, for example, Act Rapid. And when giving insulin, ideally it should be given into a large vein to avoid irritation that could occur. Something to be aware of is that insulin lowers blood sugar levels, so there is a great risk of hypoglycemia, especially if using a rapid-acting insulin. This can be dangerous if the patient already has diabetes, so it is very important to monitor blood sugar levels, ideally before treatment, every 15 to 30 minutes during treatment, and every hour after treatment, up to 6 hours. So let's have a look at a summary of which drug to prescribe when in the management of acute hyperkalemia. Hyperkalemia can be classified into 3 categories. Mild hyperkalemia, where blood potassium levels are less than 6 millimoles per liter. Moderate hyperkalemia, when the potassium levels are between 6 to 6.4 millimoles per liter. And severe hyperkalemia, when the blood potassium levels are greater than or equal to 6.5 millimoles per liter. If a patient has mild hyperkalemia and has a good renal function with eGFR greater than 60, no urgent action is required, and a simple change in their diet, where foods with high potassium contents are substituted to foods with lower potassium content. Here are some common examples of foods with high and low potassium content. Now, moderate hyperkalemia can be broken down into 2 categories, one that causes ECG changes and one that does not cause ECG changes. So let's have a look at the no ECG changes first. With no ECG change, salbutamol or insulin should be prescribed. And calcium risonium can also be added if salbutamol or insulin fail to reduce the potassium levels in the blood. In severe and moderate hyperkalemia that causes ECG changes, intravenous calcium gluconate should be prescribed. This should be done immediately to stabilize the cardiac membrane and so protect the heart and prevent arrhythmias. To actually reduce the blood potassium levels, insulin should be used. If insulin fails to reduce blood potassium levels or does not reduce the levels enough by itself, salbutamol or sodium bicarbonate can also be added.